Hello, this is EMT 204, Pediatric Overview number 2, and we're going to talk about pediatric assessments. And pediatric assessments, like any call, start with a scene size up, and we're going to take in the environment. We're going to look at the house or apartment or school or wherever we find the child. We want to look at the child's position. We also want to look for any environmental clues that may lead us to something that might be going on, such as alcohol, drug paraphernalia. There's chemicals, there's medications that aren't secured. So just observe and perhaps document or report those things. And we're also looking for signs of abuse. We'd be on higher alert than that than maybe we would with an adult patient. So as we approach the patient, we're going to use something we're going to keep going back to throughout this chapter called the Pediatric Assessment Triangle. And the Pediatric Assessment Triangle is going to give us a general impression, and this works for adults too. Just before we even touch them, as we're approaching the patient, just things that we're observing. 3 things to look for, and that is appearance, work of breathing, and circulation to skin or skin color. So we'll start with appearance. And to assess appearance, there's a mnemonic called tickles, and there's 5 things that make up appearance, and they sort of relate to each other. And first, we're looking for tone. So, does the child have good muscle tone? Are they sitting up, or are they limp, listless, difficult to arouse? Are their extremities flaccid? Are they moving, and are they resisting someone assessing them? We're also going to look at their interactiveness, and this will start by seeing if they notice when you walk in the door. So you're a stranger, and something is going on to require a call for help from the paramedics, and they should notice you when you come in. So we want to look for that. Do they make eye contact with you, or do they is there sort of a blank stare, or they're looking and they don't notice what's going on around them? Maybe they're concentrating so hard on their breathing that they don't notice strange things entering their environment. So as we get closer, we want to look to see if they try to grab a toy, or are they interested in your stethoscope or pen light, or do they just not care? And as children get older, so above 6 months old, they should have some hesitation towards you assessing them. That's actually normal. And if they don't, if they're just letting you, assess them head to toe and listen to their lungs, and they're not resisting or interacting with you, that's abnormal. Consolability. So even when children may cry while you're assessing them, they should be able to be consoled by a caregiver. So that's one of the things that we're looking for. How do they respond to the caregiver? If they get agitated by you, if they give you back to the parent or caregiver, can they be consoled by them holding them? So the look or gaze. Does the child fix his gaze? Is it straight ahead? Is there this sort of the lights are on but no one's home, sort of glassy-eyed stares? Or are they looking around at what's going on around them? Are they interested in you and your equipment? And then speech or cry. So for younger children, is their crying spontaneous? And how loud is it? And for speech, is their speech age appropriate, or is it confused and garbled? And the norms for confused speech or garbled speech depend on the patient's age. So we want to take that into consideration as well. Work of breathing. So there are some signs of abnormal breathing we will hear just without even a stethoscope, right as soon as we walk in the door. And some of those are snoring, if the child has an altered mental status, muffled speech or hoarse speech. We're concerned about an upper airway obstruction, along with stridor. We may hear grunting. We may even hear wheezing, although we probably need a stethoscope to hear wheezing, but sometimes you'll actually hear the child wheeze with just from across the room. Abnormal posture. So are they sitting up? Are they in a tripod position? Are they refusing to lie down, or does their stress level go up when they lie down? Retractions. We want to look for supraclavicular, intercostal, and substernal retractions. And in order to do that, we may not see that, especially if the children has several layers of clothing on. We may actually need to get our hands on the child in order to assess that. Another ominous sign is head bobbing. So in infants, when they're in severe respiratory distress, they'll actually bob their head. You'll see their head sort of fall forward and then pick it up as they inhale, and that's actually accessory muscles that they're using to breathe. So that's a sign of severe respiratory distress and headed towards respiratory failure. And then nasal flaring. That's another obvious sign of severe respiratory distress when we see their nostrils move with inhalation. The last part of the triangle is circulation to skin, and this gives us a clue to their cardiac output and perfusion. So one saying is that skin color doesn't lie. Just looking for pale skin, that's pale or white skin. Mottling, which is patchy skin discolorations from blood being shunted away from peripheral circulation. And then cyanosis, so blue skin, lips, and mucous membranes. And just the pediatric assessment triangle, before we even touch the patient, if we see an insult in one of those things, we know that that's an urgent patient and we're going to want to get off scene as quickly as possible. So we're just going to do a primary assessment on scene, manage what we can, and initiate transport to the most appropriate hospital for the region. And if the patient's stable, if all those three things look good, we can do a more detailed assessment before we move. So after we've completed the pediatric assessment triangle, then we're going to do our exam. And we're going to start by using the AVPU scale. And it's similar to the adults. So with alert, we're going to use their age-appropriate level of alertness. We've talked about that with lifespan development. And verbal, do they respond to their name? And then painful, do they withdraw from pain, or do they have a purposeful, localization of pain or posturing? And then unresponsive is no response to any stimulus, not pain or any tactile stimuli. So the first thing we're going to assess is their airway, and is it open, and is there adequate chest rise with breathing? And if there's not, we're going to position their airway. Usually for younger children, putting a towel or blanket underneath their shoulders and assist their ventilation. If they're in distress, we would want to give them oxygen at that point. And then for obstructions, we would want to do the foreign body airway obstruction procedures, or suction, maybe suction out nostrils is necessary for an airway obstruction. So for breathing, we're going to want to auscultate breath sounds. And we want to do this first if the child's sleeping and content on the parent's lap, because at any time it's going to be really difficult to hear breath sounds if the child's crying. So we want to do that first while the child's compliant. They may start crying as soon as we start to listen, and at least we can get that information early, because the rest of the head-to-toe assessment is more feasible to do if they're crying. We want to count a respiratory rate and check pulse oximetry. So with children, there's a Band-Aid type pulse ox probe. We have some in the lab. We can show you those later. And then also capnography. So there's some pediatric capnography on the nasal prong circuits. So circulation, at this point we're going to assess a pulse. We're going to feel a pulse for 30 seconds and double that number to get a pulse rate. And then we're going to want to feel the skin. Is it hot, which may suggest a fever, or is it cool and clammy, which may suggest shock? We're going to assess their disability using the AVPU scale. There's a pediatric version of the Glasgow Coma scale that we'll go over. We'll assess pupil response and motor activity. And there's also a pediatric pain scale that uses pictures to evaluate the child's level of pain. And we also need to expose children, because some of the things, like I mentioned, like abdominal breathing or excessive use of their abdomen to breathe, or retractions, we're not going to know that unless we expose them. And that can be difficult if they're wearing several layers of clothing, but it's important to do. We're also looking for things like rashes and even signs of abuse, bruises and various stages of healing. So we want to do a rapid exam of the entire body. And when we do this for infants and toddlers who are stable, we want to evaluate from the toes to the head. We've already done our pediatric assessment triangle. We've already determined that there's no immediate life threat. And when we're doing our secondary assessment, we want to go from the toes to their head. By starting peripherally and moving towards their core and towards their head, we're actually gaining trust. The child will actually gain trust. So as you know that you're not going to hurt them. So as you move towards their core. So history taking, that's going to involve both the child, depending on their age, and the parent. And sometimes this is done during transport if there's an insult found in the pediatric assessment triangle. So we want to ask about pain. We want to talk about the onset. Was it a sudden onset, or was this something that gradually got worse? We want to know about allergies. And one question we want to ask about with children that we aren't as concerned about with adults is their immunizations, if they're up to date or not. And if they're not, then that raises a concern about an infection or other causes that we may not need to consider if they are immunized. We also want to know about the delivery history. So if the child was born prematurely, we know that even late into childhood, they could have lung problems from that if they were born prematurely. So we want to ask about that. Were there any complications from delivery? If there was any birth injury, or if there was a complication with birth, that could have left lasting brain damage. And again, we have to evaluate whether the child's current behavior is normal for them or if it's abnormal. Last oral intake. This is even more important with children than it is for adults because kids are still at risk for dehydration. So in infants, poor feeding can be a sign of a lot of things, like an infection or even dysrhythmias. Like some of the signs of SVT in children is that they'll be irritable and they'll have poor feeding. So we want to ask if that's a symptom of another problem, and as well as their hydration and nutritional status. The other thing we want to ask about is, are they urinating and defecating? So how many diapers have they gone through? If they're having diarrhea, how many diapers are, we want to know if the baby's making urine. That'll help give us a clue about the volume status. Along with another part of the secondary assessment is assessing capillary refill, which generally it takes longer than 2 seconds. If you press the fingers or their toes, that's a sign of shock or hypovolemia. And that is pediatric overview number 2 and pediatric assessment.